We're going to switch gears a little bit. We'll talk about trauma. Trauma is a big killer. It is the #1 cause of death in our younger population, less than the ages of 45. And of all age groups, it is the fourth biggest killer in the US and in Western Europe, after heart disease, cancer, and stroke. And because it affects the younger population, it is responsible for more years of productive life loss than cancer and stroke combined. So it is a big disease, and it's finally getting more recognition, both surgically and radiologically. There's the concept of the golden hour, which came by R. Adams Cowley, which is not necessarily 1 hour, but it is a short window of time in which the rapid identification and treatment of life-threatening injuries needs to occur. This is pretty much the dirty half dozen: the traumatic aortic injuries, tension pneumothoraces, pericardial tamponade, tracheobronchial ruptures, cardiac rupture, and flail chests. Those things will probably kill you in less than an hour, and also large knives into the chest. But these are the things that need to be dealt with emergently. Basically, what we're looking for is air and blood in the wrong places. Those are sort of our big hotspots to look for. We're looking for our pneumothoraces, pneumomediastinum, pneumopericardium, and subcutaneous emphysema. And for blood in the wrong place, predominantly we're looking at that mediastinal hematoma and the presence of hemothoraces. And in continuing with the ABCs, I only got to B with broken bones and bad lines, other things that can still kill. We're hoping our next PACS upgrade will allow us to do some image editing and then treat the patient. So the menu today is going to be a discussion of traumatic aortic injuries, then go through the tracheobronchial and esophageal ruptures, and spend a little bit of time on intercostal and pulmonary arterial injuries and cardiac and pericardial injuries. The objectives, hopefully, will be to demonstrate imaging characteristics of mediastinal and thoracic vascular injuries, better understand our evaluation and approach to the abnormal mediastinum on trauma chest radiographs and CT, and to recognize the features and the pitfalls in making the diagnosis of traumatic aortic injury. Now, traumatic aortic injury is left untreated. It is a very highly fatal problem. About 60% of these patients will die in the first 24 hours, but it is a rare injury and it lacks specific clinical signs. And those things taken together put an awful lot of pressure on the radiology department, because we're really the ones who are going to make this diagnosis. Now, thankfully, the diagnosis has really evolved over the last decade. Most of this from CT advancement, and particularly the technology and use of multi-detector CT. With better spatial resolution, better speed, and proven accuracy, we've got a very good tool to help the surgeons out in this case. The typical screening chest radiograph is usually done in the supine position. You may have artifacts from the trauma board there. You may have other lines going across the patient and other artifacts. And what you're really looking for is that normal mediastinal contour, sometimes very tough to do on the supine radiograph. If possible, the patients may be able to, if they're able to, we can sit them up, and if anything, a true erect film is them sitting upright and leaning about 15 degrees forward. What we're looking for is our distinct aortic contour, shown by the arrows. Other features that we want to see are a distinct left paraspinal stripe. In the non-rotated film, normal tracheal and nasogastric tube positions, and a normal right paratracheal line. Again, these are very tough to see on our supine view, and if you can sit the patient up at all, that's your best shot at getting the mediastinum cleared. We don't use mediastinal widening. The old number of 8 centimeters has been shown that it's unreliable. Looking specifically for these contours and these characteristics of our paraspinal and paratracheal stripes is much more effective. Now, this is clearly the abnormal mediastinum. So the features we see here are we have lost our aortic contour, which would be somewhere along that dotted line. We see marked thickening in our right paratracheal region, and we've got significant deviation of the trachea over toward the right side on this relatively unrotated view. If there was a nasogastric tube, it would likely be pushed over toward the right as well. And another thing you might see is that left paraspinal line, if it extends up above the expected location of your aortic knob, that's a sign that there's probably mediastinal blood. That can actually form what all know as the apical cap. This was an aortic injury. So we'll talk about the CT evaluation. We're going to look at the direct signs and indirect signs of aortic injury, touch on some of the pitfalls, and go through our approach to these patients. Our direct signs are the following: pseudoaneurysm, by far and away the most common, contour irregularity, intimal flaps, intraluminal thrombi, pseudocoarctation and active contrast leak in the most devastating cases. Pseudoaneurysms are fairly typical to be seen in this location at the site of the former ductus arteriosus, now the ligamentum arteriosum, and often seen at the level of the left main pulmonary artery or the left mainstem bronchus. Patient also shows some mediastinal blood surrounding the aorta as well, also a very important feature to see. So the aorta is really at risk at three places. It's at the root where it's fixed, at the site of the former ductus, and at the hiatus where it goes through to the diaphragm. By far and away, the ones that survive, most of them are occurring in this location. Contour irregularity is another good sign to look for. Clearly on the image on your left, there is an awful lot of mediastinal blood, and that aorta is not nice and round, and this obviously turned out to be an aortic injury. The image on the right, a little bit more subtle, but that is not a nice round aorta, and that's a big red flag. The patient also has an awful lot of mediastinal blood, and there's also blood in the pericardial sac as well on this patient. Intimal flaps, as we can see here, this is at the top edge of a large pseudoaneurysm, a very common sign to be seen with the larger pseudoaneurysms. Again, a patient with an awful lot of mediastinal blood displacing the airway forward and to the right, and we got large hemothoraces in this patient as well. Pseudocoarctation, this is a dramatic example where we see the caliber change within the upper portions of the thorax, but sometimes it's not appreciated in the more subtle pseudoaneurysms that you don't see on the axial images as well. And sometimes it's even in the abdominal CT that you notice that the caliber of the aorta is diminished. And when you go back up, you might see that it really started off looking a little bit bigger. And this is where our oblique sagittal reformations can help when we look at the aorta in that sort of candy cane look. And we'll show some examples of that coming up. And this is a case I have to thank my friend Andrew Gelman for this. The only case I've seen of a thoracic aorta both actively bleeding and at the level of the aortic hiatus. So we've got a small caliber aorta here, we've got high density contrast material, which is our active bleed, and you can see the hematoma that's also surrounding the aorta just as it's about to descend into the abdomen. On angiogram, we see obviously a large amount of extravasation, but we also see early filling of the IVC from a fistulous connection. This is a patient with an intraluminal thrombus, what has been sort of nicknamed the minimal aortic injury, and probably the only aortic injury that has been shown to do okay with observation rather than surgical management. We see this very sort of clearly on our transverse image. The candy cane view, the oblique sagittal MPR shows this very nicely, and it's also helpful for in other ways that it shows us the great vessels and how close the lesion is to the great vessels. We can also do some cute pictures for our surgeons. Doesn't do us a lot of good, but they all like these pictures, so we do occasionally for them. This is an angioscopic view. Basically, you're navigating through the aorta, and you can see the lesion poking out right there. This is, again, just to stress the idea of using our MIP projections in our sagittal MPRs to look at this is a very large pseudoaneurysm, but the surgeons want to know how close this is to the last branching vessel, if there are anatomical variants. In between the oblique sagittal MPRs and the 3Ds, there's a lot of information that can be given to the surgeon very quickly and without an awful lot of your efforts in making these images for them. Very useful tool on this large aortic pseudoaneurysm. So the indirect signs, basically what we're looking at are mediastinal hematomas. And here we have a nice large anterior mediastinal hematoma, but we have a good reason for it. We have a sternal fracture, and we can see the contusion within the patient's left breast here. And the aorta showed no direct signs, and there was no aortic injury. Another example of mediastinal blood, we can see an awful lot of blood in the upper mediastinum. These are our great vessels. Coming down around the level of the arch, again, an awful lot of mediastinal blood. There were no direct signs of aortic injury on this case, and because I had just finished reading the person's cervical spine, I had noted this very large distraction injury between C2 and C3, awful lot amount of blood that had filled the prevertebral space and tracked down into the superior mediastinum. This patient did not have an aortic injury. This was a bit of a frightening case when I was a fellow, just about to leave for vacation, and I was doing the night shift, so I had nobody else there. The gentleman showed up with this radiograph, which obviously I found very concerning. We have all of the features that concern us. We've lost our aortic contour, we've shifted our trachea, we've thickened our right paratracheal stripe. Our left paraspinal line, wherever it is probably extending up and maybe forming a small apical cap. But for every reason that I've shown you, and for any single one of those reasons, we obviously went to CT. When we went to CT, this was our scout view, and our sort of right apical or extrapleural collection was now expanding in size. This got me a little bit worried. But when we scanned the patient, I saw this. There were no direct signs of aortic injury, but an awful lot of mediastinal blood. We can see we've significantly pushed the airway way forward off the spine, and we have a couple foci of very bright, dense contrast material. This was very concerning for an active hemorrhage going on in the chest. And me being the image till teaching file complete kind of guy, once we finished scanning the abdomen and pelvis, I ran back up to the top. The patient was still stable, and I rescanned his mediastinum. And we can see that the contrast is now expanding through that mediastinal blood, and it's also enlarged in size, which was again also concerning. Now I saw absolutely no direct signs of aortic injury, and I'm sitting here thinking I'm going to kill this patient, and I need to figure out what the next thing to do is. So in that instance, of course, we TURF. So TURF the patient to angio, which was still probably the next best move, but we can see that this right extrapleural collection has now expanded again in size. And they found no aortic injury nor any other actively bleeding vessel. And our angiographers came in within probably 2 or 3 hours from the time that we started. I this time was frantically going over 3Ds, MPRs, and trying to figure out what was going on. So I came up with this sagittal image, and I saw that some of the active bleed was actually occurring quite remote from the aorta itself. The great vessels actually looked okay. But what I saw in the cervical spine, there was this small little extension injury, but these large hook osteophytes. And the best guess that we could come up with, and so far the one that's holding to date, because we have no autopsy, because the patient survived, was that some unnamed vessel got pierced against those osteophytes and was actively bleeding. So mediastinal hematoma is a great marker for flagging your radiographs as being abnormal, but without your direct signs, it often does not pan out. So how good is CT for aortic injury? Well, back in 1998, Stu Mervis from Shock Trauma showed on single detector helical CT that we can achieve a sensitivity, specificity, negative predictive value, and accuracy of virtually 100%. It is an excellent tool, and with multi-detector CT, these numbers, obviously, they're probably not getting much better, but our confidence in making these calls is getting better. So what can throw us off? Certainly atherosclerotic ulceration with big ulcers in patients with a lot of disease. Pulsation artifact is a big one. The normal ductus diverticulum. Chronic pseudoaneurysms, because again, once a trauma patient, always a trauma patient. Very subtle injuries are out there. There are streak artifacts, which can happen from the contrast bolus or other lines and staples and other leads going across the patient's chest. And atypical locations, such as we saw down at the diaphragmatic hiatus of the aorta. The key to separating a lot of these from the truth is looking for that presence of the mediastinal hematoma. Again, in the atherosclerotic patient, in the normal ductus diverticulum, in the chronic pseudoaneurysms, we shouldn't be seeing a mediastinal hematoma if these things are not acute. Now, this is an unfortunate individual that was made an example of on the trauma.org website. He has pulsation artifacts, but it was not appreciated as being pulsation artifact. It was thought to be an aortic injury at the ascending aorta. And so this patient is what they termed a victim of medical imaging technology. Surgeons took him to the operating room, cracked his chest, and found a normal aorta but no mediastinal blood. So they often associated this now with the brainless application of radiologic findings, so it's not all on our shoulders now. This was a subtle injury. It occurred New Year's Eve last year, and patient came in with a concern for an aortic injury, was transferred from another hospital, and this was a scan done at our institution. We do have, as we can see here, there is some mediastinal blood, which was called and told, said it was venous origin, which we all hope it certainly is, except unless we see that contrast blush. But no direct signs of aortic injury were appreciated at the time. There is, and I'm, picking out the easy images now, there is an intimal flap that we can see at the bottom end of a very subtle pseudoaneurysm. And perhaps this isn't quite perfectly round over here. But one tool that was not done, which would have been very helpful, which I was able to do after the fact, was to do our oblique sagittal MPR, show a beautiful pseudoaneurysm, which is not well appreciated on the transverse images, and lo and behold, it looks very much like the angiographic example. So it's a very good problem-solving tool. So our approach with these is basically if we have an abnormal radiograph, we go to CT. No ifs, ands, or buts. If we see direct signs, these patients go directly to thoracotomy. They do not stop by angio just to increase, our chances of missing the golden hour. We go straight to the operating room. Now, in the absence of mediastinal hematoma and direct signs, we have excluded an aortic injury, and we're done with concern for that. If we have a mediastinal hematoma and we can blame it on a fracture, whether it's the sternum or the spine, and we have no direct signs of aortic injury, we have excluded that as a diagnosis. Now, there's the caveat, though. If you see mediastinal blood, and it is in contact with your aorta, but you don't see direct signs, I will always kind of stress to the residents, try to do these MPRs or your MIP images first, get another look at it from a different way, see if those subtle injuries are there. And if there's still any question, by all means, turf it to angio. It is the next appropriate examination. It still is the gold standard in the literature. Okay, we're going to change gears a little bit. We'll talk about tracheobronchial and esophageal ruptures. Airway injuries, thankfully, are uncommon, but they are highly lethal, no surprise. And I remember this from a board exam, and it's actually true that bronchial tears are more common than tracheal, right side more than left side, and often occurring within the first 2.5 centimeters distal to the carina. Nonspecific findings on our radiographs include air pretty much in the wrong place, so pneumothoraces, pneumomediastinum, and subcutaneous air. Specific signs on radiograph would be a persistent pneumothorax despite a good chest tube. Clinically, this fits with the leaking chest tube. When they put it down to the water seal, it continues to bubble and bubble and bubble, so air is continually coming out. What we might see radiographically is a fallen lung sign, and if there's an endotracheal tube in place at the level of the injury, you might see this overdistended and herniated through, and we'll show examples of these. This is an example of the fallen lung sign. We've obviously got a large pneumothorax on the left, a collapsed left lung, and we can see pneumomediastinum tracking up as well. So this is from a bronchial rupture. This is a tracheal rupture, an example here with the ET tube in front. Rip through the membranous portion of the trachea. This is often in relation to blunt trauma occurring in this location. If the ET tube and the balloon are at that same level, the balloon may herniate through and give you this dumbbell appearance. Now, this is a poor individual that was actually shot through his trachea from one side to the other, and when his balloon went up, he made a little bit of a Mickey Mouse appearance. Not a survivable injury, and provided us with nice pathological correlation. Here's the trachea. The ET tube was placed and blown up, showing exactly pretty much our same picture. I want to thank Stu Mervis for this. And this was a braver individual than the last. He decided to catch the bullet with his trachea. The bullet went into the front, pierced the anterior aspect of the trachea. We can see the air around it. And then he decided to aspirate the bullet so it wouldn't go any further, and it wound up down in his left lower lobe. This is a tough guy. All right, esophageal injuries. Most of these are related to penetrating trauma, but we have seen a couple of these pop through from blunt trauma. Because of the nature of the anatomy, we're mostly dealing with the cervical or upper thoracic esophagus. But this is the most highly lethal GI injury you can have. Mediastinitis will kill these people very often in the first couple days post-injury. We can reduce that if we identify these injuries early and get treatment instituted very quickly. What we'll see on radiographs are nonspecific. Again, air in the wrong place, so pneumomediastinum, left-sided pneumothoraces are common with this, and subcutaneous emphysema. You may see left-sided pleural fluid and left lower lobe atelectasis. CT findings will look very much like the radiograph, but we'll hopefully see some mediastinal fluid, and if oral contrast is given during your trauma CTs, you may see that extravasate out. It may also throw you off to think that you may have an actively bleeding mediastinal hematoma. The ultimate diagnosis is still going to come with an esophagram using water-soluble contrast. This was a 9-month pregnant lady sitting in the back of a cab on 42nd Street in the springtime this year when the cab decided to play pinball with a bunch of other cars on the street. And she suffered a blunt esophageal injury. Also, if you can tell, there is a subtle undisplaced hangman's fracture here, a very sort of uncommon combination. But we have air in the wrong place, tracking up in the prevertebral soft tissues. Went on ultimately for the esophagram, which showed the leak and confirmed the esophageal injury. So we'll switch now to a couple other vascular injuries that can occur. These are a little bit less common, intercostal and pulmonary arterial injuries. This is a case we had, we can see it's our initial phase of CT in our delayed image over here where our contrast is washed out from the aorta, and you'll see why I did this. We've obviously got a dense hemothorax present on the left side. There is a contrast blush that's tracking through here. On delayed images, we show that this contrast has expanded and diffused itself through to show us that this is actively bleeding. There's the fracture, so this is an active intercostal artery bleed. Another example, same diagnosis, an active intercostal artery bleed, this time even large collection of contrast and blood that's starting to clot within there. This patient, had no fracture. This is a little bit of an unusual one, but just to show that this injury can happen, I want to thank again Stu Mervis for this. We had this little light bulb go off in the right side of the patient's chest, and on the sagittal images we saw it in the superior segment of the lower lobe. Small hemothorax as well associated with this. This turned out to be a pulmonary artery pseudoaneurysm. 3D images were very nice to demonstrate its connection with the pulmonary arterial tree, and verified again on the angio where the angio guys were able to coil this. A little strange bit of trauma, but it's out there. So lastly now we'll quickly go through some cardiac and pericardial injuries. Our blind spot really is looking for those cardiac contusions which we don't see. Typically we're looking for our hemopericardium. This is something your trauma surgeons, or if you're out there doing these, might see on a FAST. This is your subxiphoid view looking at the heart here with obviously some fluid collection around the heart. Often this is an indication that they'll go straight to the operating room. Occasionally we see these in CT, a hemopericardium outlined over here. Of course, with blood in the wrong place, we can also have air in the wrong place. Patient with a right-sided pneumothorax, we can see air in the pericardial space. So this is a pneumopericardium. But the thing to be on the lookout for is what's happening over here. This is tension pneumopericardium. We've got flattening of the right-sided chambers of the heart, so just as blood can cause tamponade, air can do the same thing, so be on the lookout for that sign. This patient also has extensive contusions, bilateral pneumothoraces, some atelectasis, and probably some more packed-in contusions as well. And lastly, I'll leave you with this image, hopefully something we don't ever see. This is that kind of yin and yang appearance. When I saw this, I started telling my colleagues, wow, I scan dead people. This is asystole. This patient had already had his CT of his head and his face and his cervical spine, and during the contrast injection, the patient actually arrested on the table. The scanners are so fast these days, we wound up beating everybody into the room to treat the patient, but we wound up with some pretty pictures of a contrast refluxing into the right side of the heart, down the IVC, refluxing to the right hepatic vein, and refluxing into the renal veins. So something we hope we don't end up seeing. So again, I'll leave you with the list of our dirty half dozen. These are the things, and all thoracic in nature, that we need to sort of be on the lookout for. Our aortic injuries, tension pneumothoraces, pericardial tamponade, tracheobronchial rupture, cardiac rupture, and flailed chest.